Hi, welcome everybody. Pardon me. Thank you for joining us today. My name is Kristen Jacobson, and I am the new CEO of Solve. I'm very pleased to be here. I have been in the patient advocacy space for many years and in healthcare for my whole career. I joined the Solve board in April, and pardon me, I then joined as the new CEO recently in October. So I'm generally very new, but I'm really excited to be here. I feel like this is such a huge unmet medical need, and at the same time, it is also we're at the brink of some really important discoveries. And so I'm just really looking forward to helping all the amazing advocates and all the amazing clinicians and researchers that are in this field continue to progress us toward really important treatments and just making a meaningful impact for patients. My colleague, Tim, is with me today, and he is our Chief Scientific Officer and joined us a couple of months before me. And so, I'm just really happy to have him, who will be talking to you a little bit later in the program. Next slide. All right. I wanted to mention and thank Novavax for being a funder of this. This event is funded in part by an educational grant from Novavax. And then there are a couple of other disclosures on the screen you can just take a quick look at. All right, next slide, please. So it is my great pleasure to introduce our three panelists today. The first one is Dr. Melanie Hoppers. She's a distinguished physician and Chief Medical Officer of Physician Quality Care, and she's dedicated her career to the diagnosis, treatment, and management of complex medical illnesses. She got her MD from the University of Tennessee and a dual residency in both internal medicine and pediatrics. And since 2019, she has particularly focused on conditions such as ME/CFS, long COVID, and related comorbidities. Also, in addition to her clinical practice, she is involved in several clinical research projects really focused on improving patient outcomes, and is also a compassionate advocate for patients facing complex medical challenges. Thank you for joining us, Dr. Hoppers. Next, we have Dr. William Pittman. Dr. Pittman attended Albany Medical College and did his internal medicine residency at Cedars-Sinai Medical Center. And then he joined UCLA as a member of their complex care clinic. And he has a focus on treating medically complex patients. He currently is co-director of the long COVID program at UCLA, and he developed an interest and expertise in the management of patients with ME/CFS and other post-infection syndromes. Last but not least, we are joined by Dr. Tiffany Walker. She's an assistant professor of medicine, internal medicine at the Emory Medical School and on faculty at the Grady Memorial Hospital, co-founder of the Grady Long COVID Clinic, and also established a long COVID registry and biorepository. She's a principal investigator of a number of studies, including the Atlanta Long COVID Collaborative and the NHLBI Recover Initiative cohort, and the Recover Vital Paxlovid trial, among others. Her work is actually funded by the Alzheimer's Association to characterize the neurocognitive sequelae of COVID-19 in older African Americans. And she investigates innate and adaptive immune dysregulations of long COVID. Thank you all for joining us today. You can take down the slides, Monique, and we're going to start with a discussion. Terrific. All right, so I would love to have you start and reflect on how treating long COVID patients has informed your treatment of ME/CFS patients, and vice versa. So it would be great to, talk about that and just talk about your entry into the field.
Sure, I can start. So I didn't have any knowledge of ME/CFS prior to long COVID. I really got into this space about 2.5 years ago when we founded our long COVID program at UCLA. And what I quickly found is that although this was advertised as a completely new illness, I found that many patients were falling into categories that we have seen and known about for decades, including a phenotype that's nearly identical to ME/CFS. So I do think of long COVID as really multiple different phenotypes, multiple different syndromes, of which one is clearly related to ME/CFS, and I treat them virtually identically.
Yeah, and I would say my experience is very similar to Dr. Pittman's. So I had heard of chronic fatigue syndrome before, but knew very little about ME/CFS. And when I became involved in long COVID, it seemed like a whole new world, a whole new disease. And as I learned more, it became very clear, like he mentioned, that ME/CFS was a phenotype that was really predominant, I think, especially in individuals that are about 6 months or further out. I think a very large majority of individuals with long COVID have the ME/CFS phenotype. And honestly, I've learned the most from patient advocates regarding ME/CFS, because I think even within the medical community, there's still very little understanding. There is very little research that has been done and been funded in that space. And I think we find ourselves a little flat-footed when we have a disease like long COVID that's happening, globally at such a high rate, that we are getting these post-infectious diseases like ME/CFS. And we say, oh, well, this is something we probably could have learned from before the advent of this pandemic, and could be multiple steps ahead were we to have had that investment in research.
My experience, I guess, is sort of the opposite. My focus was on ME/CFS, and I wasn't really thinking about long COVID at the time. I was so focused on ME/CFS, and when I went to do more training to learn about it, that's when that came more up on my radar. And the treatments and things I do for long COVID are modeled from what I've used for ME/CFS. So.
And maybe you could, maybe back up just a little bit and maybe talk a little bit about how each of you kind of found this space and started treating patients with ME and long COVID, and maybe also, start talking about a patient's typical experience at your clinic. Maybe about how often you see them. Are you diagnosing and treating? Do you see a lot of in-town, out-of-town, wait time? Just kind of how does your clinic work? So how did you get into the space, and then how does your clinic function?
So I can start again if you'd like. Like I said, we started about 2.5 years ago at UCLA. I actually got into it because we had established at the very beginning of the pandemic a COVID monitoring program. We didn't have drugs. We didn't have much to offer. All we could do is monitor and send them to the hospital if it got severe enough. And so we had developed this monitoring system with physician extenders and others. And eventually we extended the monitoring past the initial infection point. And we started to see that these patients were continuing to have symptoms right from the beginning, before anyone was even talking about long COVID. And that got us interested. And once we started hearing about this long COVID thing, then we transitioned that group into the long COVID group because there were more drugs available. Every PCP at that point knew how to monitor patients with long COVID or excuse me, with acute COVID and treat them. And so we switched our focus over to long COVID. What I'd say about our clinic is I actually work in 2 clinics. So I have a private practice and then at UCLA. At UCLA, we have more patients than we could ever treat. Unfortunately, the wait time has become very long. This is a true second pandemic, really. And so we see them every 3 months, 6 months. It depends. And the wait times, unfortunately, are quite long. But we're trying to recruit more people into the space. That, as I think was mentioned, the interest by many physicians and the knowledge by many physicians is truly lacking, which is unfortunate. But hopefully, we'll eventually be able to recruit more people into the space and broaden the access.
Yeah, and so at our institution, so we have 2 sites. At Emory, we have a clinic, and at Grady, we started noticing at the end of 2020 that we're having these long-term sequelae of COVID. And so we opened these clinics at both sites and have been seeing patients since end of 2020. The wait time's the same. It can take between 3 to 6 months to get into clinic. We can see patients about every 3 months or so at the Emory clinic. The Grady clinic, it was a little bit longer, every 6 months or so. Because of limitation in resources, we actually had to close our Grady clinic. But with the recent award of an AHRQ grant, we're able to reopen our Grady clinic. This is a large urban safety net hospital, and we'll be able to provide care to these individuals that are at higher risk for long COVID. So hopefully with the support of this grant, we'll be able to see patients more frequently and have decreased wait times, but we're running into the same things. It's very challenging to be able to see the patient load that's coming our way and to have the resources to support the care.
So mine is, I got into seeing patients with ME/CFS for the same reason that I see a lot of people do. Is it was my daughter has ME/CFS, and there was no one to help. Everywhere I went, I went several large centers, and there's just no one even. I don't know if they didn't know what it was or they didn't know how to diagnose it, but there was no help. And so I sought out help. Bateman Horn Center has helped me with my daughter. They helped me learn how to take care of these patients. They're very committed to, as Solve is, to sharing information and resources and providing that for other providers. So that's how I got started, was basically in searching for help for her. Then I realized that there's other people here. And at my clinic, people wait about 1 to 2 months. I'm certain, obviously I don't have the same resources that you guys do, but I'm in a town of 8,000 people, but we have about 100-mile radius that we serve, and we stay very busy.
Excellent. Can you talk about what treatment protocols you find most effective for patients? Are the protocols generally the same for each patient, and sort of what are some of the treatment differences for like extreme fatigue, post-exertional malaise, brain fog? That would be helpful. Thank you. Who would like to go first this time?
I could talk for about 3 hours on this, but I would say it all starts with pacing. I mean, I think that's it, with the ME/CFS phenotype, that's at the core. I can talk about a lot of treatments, but I don't think that should distract from the very core. Pacing is quite challenging to do. It's not simple. It's not easy, but it's very important. And in the past, people were recommended to keep journals, and now we have apps and things, which I know you'll talk about later, that can help track their activities. And also I find biometrics to be important. Just personally, in my experience, heart rate and heart rate variability tend to worsen when people are overexerting, and especially in the post-exertional malaise period. And so monitoring that with a heart rate monitor is very important. I usually use an upper arm band because those tend to be the most accurate. And then there are a variety of apps out there, including one from Solve, that can help monitor those things. So that's at the core of it. I can talk about a lot others. what I'd say very in short is there are other syndromes that can cluster with ME/CFS, for example, POTS and dysautonomia. For example, I'll call it mast cell spectrum disease because the whole MCAS diagnosis is a little bit controversial, but these types of things that if you can get clued into, or hypermobile Ehlers-Danlos, for example, if you get clued into these things, then there are treatment strategies for each of these things separately that can be implemented and tend to be a little more successful than just general treatments for ME/CFS. So I'll stop there. I could talk for hours and let the other people speak.
Yeah, and I think at least with the ME/CFS phenotype is really working with your physical therapist to make sure that they are very aware of post-exertional malaise and understanding that the rehabilitation schedule shouldn't include intense workout that's going to trigger post-exertional malaise. I think that even among physical therapists, there's also not as high level of knowledge of ME/CFS that we really require for these patients. So more awareness about it, I think, is really helpful in your entire multidisciplinary staff. Treatments that we've tried in our clinics, I think very low risk, trying antihistamines in some patients have been helpful. Very hit or miss though. For some people it works for them, for some it doesn't. We haven't used it yet, but I'm very interested in trying low-dose naltrexone. The Stanford group just put out a paper showing that low-dose naltrexone has been very helpful in their patient population. It's been shown in very small clinical trials in ME/CFS even before long COVID. So those are two of the treatments I'm interested in right now.
I agree with both of you guys. Again, like you, pacing is the first thing I talk about at our first visit. I talk about it every visit. I refer them to videos to watch, just to reiterate what I'm saying, give them examples. Sometimes it depends on how severe you are. I may need you to, pace just getting up and going to eat. And people aren't used to thinking about that. So I think that's really, really important. Again, depending on what you find, I check everyone for orthostatic intolerance. I do a lean test, poor man's tilt table test. And I think the statistics are 80% of people with long COVID have that issue. And so, there's a great place to start with some treatment, sympathetic overdrive, brain fog. There's lots of neat little things you can do to improve. I try to find something quickly that will help the patient, kind of the low-hanging fruit, because if you can do a little something for the brain fog, then that just makes them feel so much better and have hope. LDN is great. I use it quite a bit. If I had one tool and that's it, for me, that would be the one. But again, like you said, everyone's different. Some people have a strong MCAS component, and I do address that. Again, everyone's different. And the biggest thing is to listen to your patients. Listen. And when you do something and you come back and listen to what happens, if they tell you that a medicine did something that you don't think is typical, it didn't mean it didn't happen. So listen to what the information you get. And I have learned more from my patients than from anything. So just, stay in close contact and listen to what they say.
Yeah, because it seems, I was just going to tag on to that. It seems like, I'm not sure that's been borne out in studies, but it seems that there is a hypersensitivity to a lot of medications in this patient population. So even smaller doses for them that would work on other individuals might cause reactions, to Dr. Hopper's point.
And Dr. Hoppers, could you just define LDN for people in the audience?
Sorry. Yes. Low-dose naltrexone.
Okay. Excellent. And I'm going to just follow up with one of the questions from the attendees. So for patients who are severe and bedbound and unable to go to an appointment without significant exacerbation, and even telehealth is challenging, how do you recommend that they interact with their doctors? Are there any suggestions that, can help improve their care and quality of life?
I use email. That way they don't have to have a verbal interaction. They can email me.
And I also have patients that have a spouse or a family member that can communicate on their behalf. So that can be helpful as well.
Terrific. Let's see, we are kind of out of time for this section, so I might move on to the second section, where we're going to be talking, well, I guess the last thing I'd ask in this section is around what are the best alternatives if no clinics are available in your area, or you can't get into clinics? Is there a type of specialist you'd recommend in the absence of a long COVID specialist? And are there any tricks or tips you would provide for patients who are seeing non-specialists in terms of how they communicate about their post-infection disease, especially when tests are coming back normal?
Be your own advocate. The best provider you can find is one who will listen to you and work with you. And it's helpful if a person comes in with a little bit, maybe a timeline, a little bit of information on a piece of paper, so that you don't, when you have brain fog, it's hard to remember all the things, and it's hard to remember them maybe coherently. So while you're home and you can pace putting that information down, it's helpful to get that information. So even if you go see, say, your primary care provider who doesn't know anything, if you have one that listens to you and you can break it down into these pieces and share resources with your provider, even they can find the information. But it's helpful if you don't overwhelm the provider, in my opinion, with way too much information at one time.
Yeah, and I think using your intuition and getting a feel, to Dr. Hopper's point, on whether this physician is open to understanding this disease, because I do think that we have a lot of work to do as clinicians to educate our fellow clinicians about this disease. And some are just not open to it. If you get that feel, that's probably not the physician for you.
I often tell patients, not just in this space, but in general, because patients ask me, how do I know what a good doctor is? I tell them if they're curious.
Mm-hmm.
Plain and simple. If they're curious, they're likely to be a good doctor.
Nice.
Now, you guys talked about needing to get the physician community and the medical community educated. Do you have ideas about how to do that? It's obviously a big priority of Solve. It's one of the things that we'd like to do, is specifically do some fundraising around maybe creating a CME program for physicians. But I just, if you have any suggestions on how to educate the medical community, that would be terrific.
Yeah, we have a lot of interest at our site in doing peer education. And so some of our approaches are, we'll do it initially at our institution, where we do road shows and primary care education series, but we really want to expand it to the region as well through webinars, much like this. And then we're also interested in building kind of basic protocols that really will make sense for a primary care provider, especially out in the community, to be able to use that as a resource to treat long COVID patients, since it can be kind of complicated. And then in addition, a network that I work with in long COVID, we're interested in doing podcast as well, that can be both disseminated to providers to increase awareness and understanding of long COVID and ME/CFS and dysautonomia, but also for patients as well.
Excellent. Thank you. I would be interested if you could share your comments and considerations for vaccinations for your patients. How should your patients think about it? How should your caregivers think about it, if that's different? And can you share any thoughts on the different, types of vaccines that are out there, in terms of just considerations that patients and caregivers should have?
I think will likely be a very different experience among the three of us, based on geography. In LA, you have to convince people not to get more mRNA vaccines. They're trying to get it like a month after they've gotten the last one. And I've seen some people who have long COVID and ME/CFS, particularly long COVID, not do well with some of the vaccines. The vast majority of people do. I've been trying to figure out what the phenotype is of the people who don't do well. I think oftentimes people who have some sort of autoimmune component, even though we don't have an antibody to test for because this is a novel disease. If I'm getting that feeling, sometimes those people don't do as well. But in general, people do very well with them. Because everyone gets all the mRNA vaccines, I don't really have almost nobody's gotten Novavax, so I don't have a lot of experience with that.
Yeah, usually what I say is the vaccine cannot guarantee you won't get COVID, but it decreases your risk of developing COVID, which therefore decreases your chance of developing long COVID or the ME/CFS related to COVID. And then there's some evidence to support that maybe the vaccine itself could be protective against developing long COVID, even if you develop COVID. That data is still somewhat equivocal. But I find that I think the evidence supports the folks that tend to get the dysautonomia phenotype more often tend to be folks that are younger. That can, to some extent, be true in ME/CFS as well. And these are the patient populations that may not be opposed to the vaccine, but don't take it because they're not going to have some really severe sequelae of acute COVID. And they may not have the knowledge about how severe the sequelae of long COVID can be. And so I feel like that's a real target population to reach out to and explain how bad long COVID can be and what their true risk is of developing long COVID. And that's one of my strategies.
In my community, I think opposite from California, we don't have a mad rush for mRNA vaccines. I am glad that we do have an alternative available. I've been waiting for it. And, first we had to get approval in the US and then we had to get it to our area because once it was approved, it was quite a while. But now I was looking at this last night, actually, just to see where all it could be had in our area. And I did see that it is pretty much available. I think there's a pharmacy that distributes it. You can go to every one of those pharmacies and they'll have it. So we do have that available now. So that's I like to have the alternative. I think that's really helpful.
Excellent. Tim, I would love to have you introduce yourself quickly. And then if you could just tell us a little bit about Solve Together. It may actually be useful to the question about severe patients in terms of its ability to kind of pull medical information together from multiple sources for patients so that they don't have to put it together themselves. So if you could introduce yourself, and then Monique, if you could just put up the first slide, that would be great.
Thank you, Kristen, and all the speakers here. My name is Tim Xiao. I'm a new Chief Scientific Officer for Solve. So my background, my most recent background at NIH was from the National Center for Advancing Translational Sciences. And so therefore, my focus is also always about bringing new clinical research methods to benefit the patient cohort and populations. So the one thing I really appreciate hearing from all the providers here is about the challenges for patients to keep journal for their activity and for how they experience fatigue. Monique, if you can advance to the Solve Together slide, that'll be great.
Slide 10.
Yeah. So when we design our new data platform, we actually collect a lot of patients' feedback, and therefore you will see a lot of features that will be exactly fitting your need. For example, we do hope that all the data we collect from the patient will be empowering the patient themselves. So as you heard about, that it's hard for many physicians to actually get a full view on your health situations. Yet, as we develop new tools, we factor this in. So we allow a patient to actually consolidate all her or his data from multiple clinics, including with the permission to incorporate the health records from different clinics. So therefore, when you decide to move to a different clinic, and then you'll be able to port your data with you, and your new provider will be able to see it. And this is important because as you heard about, it's so hard to get appointment with providers. So we hope that you will be able to present the most holistic view for all the records you've collected to your providers. Secondly, we do carry a pacing function, and this is done in an app and on your smartphone. And then this will allow you to port the data from your wearable to your smartphone, and you can monitor your health situations in a real-time manner. And then you can also use this to actually export this data, and so that your care provider can also see how you're up and down during the day. So importantly, I want to also talk about this part about monitoring your health. This is our understanding that we can potentially leverage this to help conduct more research for the patient who are experiencing the most severe symptoms, because they are the one who actually cannot come to the clinics at all. And so as Saul, we've been thinking about applying new research methodology to reach to this patient and use remote monitoring technology to actually help physicians and researchers to collect the data without patient to come into the clinic. So I think that's a part that we want to use to accelerate research for.
Next slide.
So next slide, please. So another thing is that attached to our Solve Together real-world data integrators, we're also using this platform to connect patients with clinical researchers. So you have a task force behind this platform to actually actively looking for clinical trial opportunities and to connect patients with the researchers. And we actually boast our capability to actually expedite the clinical trial recruitment for any clinical researchers, and therefore reducing the timeline as well as the cost for any trial. And by doing that, we hope to actually encourage more and more clinical researchers to investigate into this space. And for the currently on our platform, we accept all the US adults to join Solve Together, and many for the condition of ME/CFS and long COVID. And you can also sign up as a healthy control, because we do need a healthy control to help. So there are various ways that you can actually support research in this field. And you can scan the QR code on the screen, and they'll take you to our Conform and the introduction page. I hope that many of you will be interested in joining us. Thank you.
If the panelists could comment on, you know, the usefulness and importance of being able to have this kind of data, and what kind of information from patients is most helpful for them to share with you when they come to see you.
Yeah, so definitely, you know, our goal, you have your research goal. Our goal as a clinician is with this data is really to reduce post-exertional malaise, help the patients feel better. And so getting the information about their symptoms. And then, like I said, I do like biometrics like heart rate and heart rate variability to try to figure out where their threshold is. And it can be quite complicated, because I tell patients that exertion, I think of it anyway, as in 3 categories. There's physical, cognitive, and then emotional exertion. And so there's this milieu of multiple things going on. And so if they can log their emotional state, any cognitive, any physical exertion that they've done, then their symptoms, and we can try to correlate the two along with the biometrics. It's complicated, but that would be how I would go about it.
Yeah, I agree. I think it's very useful, especially tracking the symptoms on more granularity than we have, both from a clinical standpoint and tracking response to treatment and therapeutic approaches, but also from a research standpoint. We have some good longitudinal studies right now, but not the level of granularity of what's happening on a day-to-day basis. So we know this is a disease that waxes and wanes over time, but what causes it to wax and wane, and how much does it wax and wane, and really characterizing that further, I think would be really helpful. And also finding, I think that will help us better understand triggers of what causes these flares as well. So I think all this data could be used in that way.
I agree. I think the biometrics are helpful to the patient because, you know, they don't, post-exertional malaise is a delayed response. You feel fine when you're doing the activities. Typically, it's going to be maybe 24 hours, 48 hours, 72 hours before you have the repercussions. And so following that data themselves is very helpful, just looking at their heart rate variability, those kind of things. And I'll just comment, I went on the other, not too long ago and joined Solve Together. And it's really neat because it tells you how difficult the activity is before you do it. So that's really helpful. They've really thought about it and how it impacts a person trying to get through it. And they really are short little pieces of energy that it takes to do everything. So that's really, whoever designed that did a good job.
And I understand that apparently it also will send you a notification if it thinks that you need to slow down or take a break. And I'm not quite sure how they program that in, but I've heard from patients that that feature has been helpful for them.
That is good.
Let's see. Can you talk a little bit about what new breakthroughs and discoveries are giving you the most hope about better diagnostics, treatments, and cures that might be on the horizon?
I think I'm most encouraged by having some rigorous studies understanding the underlying pathophysiology of long COVID. So what is happening in the body that's causing these symptoms? I think we still have a long way to go, but it's really important, especially for those that don't understand long COVID or don't believe it's a real disease, to be able to have a mechanism you can point to and say, you can't deny that this is truly a disease. This is not something that's in people's head, especially, 30 million people in the United States. So I think that is a really good start to just providing credence to at least the scientific community that this is a true disease. But it also helps us understand better targets that we might be able to treat, because I do think we're behind the 8 ball in finding effective treatments for long COVID. I don't think anybody would argue against that. So really knowing what we need to target, but also in parallel with repurposed drug trials, because I don't think we need to wait 10 years to start trying treatments for long COVID. Everybody's been suffering long enough.
And it's nice from the ME/CFS perspective as well to just see this much attention brought to the disorder. It's been neglected for too long.
That is the silver lining of this pandemic, fortunately or unfortunately. Yeah, I think Dr. Walker's absolutely correct that we need to figure out the pathophysiology, and then also repurposing drugs. I'm very shortly going to be involved in a trial using nimodipine to increase cerebral blood flow, which has been shown to be reduced in patients with ME/CFS with or without POTS. So things like that, repurposing drugs is going to be very helpful. And I'm excited about, I know people all over the country are doing a wide variety of different trials looking at repurposing various drugs. So I'm excited.
Thank you. And we hope you'll be able to join us. And if you have any suggestions, send them our way of how to get pharmaceutical and the biotech industry involved, because they are relatively uninvolved in terms of the amount of money and research that they're putting into this. And I don't know if you have any thoughts of, what are they looking for, to get, or any thoughts about how we might get them more involved. I mean, I think some of what you just talked about, kind of sets the stage for that, but any other thoughts would be welcome.
Yeah, I think that I'm also interested in repurposing drug trials. I think the challenge when going through pharmaceuticals is, of course, it has to be a benefit to the pharmaceutical agency. And if these are medications that are generic, then that becomes challenging. I think that we need to have more funding from a federal standpoint. And I think that, honestly, it's the patient advocates that we're able to advocate for the long COVID funding that we have received through the NIH to run these meta cohorts and these clinical trials, and just bringing attention that we're not done, that there's a number of clinical trials that need to happen. I think you can be empowered as patients to advocate to your leaders that this funding is really necessary. And I think the more vocal we are as both clinicians, researchers, and as patients, the more likely that we are to be funded for this incredibly prevalent disease that is debilitating for people. We really need the funding to be able to run these trials, and I think that will come through federal funding.
Monique, could you go to slide 13, because that's really kind of a perfect segue. Okay, if you could go a couple earlier, I must have gotten the number wrong. One more forward. Excellent. So I think one of the things that we wanted to talk about, because Solve actually, and Emily and her team in particular, played a very significant role in working with other groups and kind of co-leading the effort with the federal government to get the $1.25 billion that went into the NIH for funding for research. And, while people can quibble over whether it was enough or whether it was spent in exactly the right ways, $1.25 billion focused on this condition and this set of conditions is a huge difference compared to the $5 to $15 million a year that ME/CFS was getting before it. ME/CFS was, I think, is still maybe the least funded condition with the highest disease burden. So, these are, we're hoping that you're enjoying this free webinar. We have a bunch more time. We're going to take a bunch more questions, but I would be remiss in not, letting everybody know how important supporting organizations like Solve are. This is a free webinar. We do a lot of educational events like this for patients. We do our advocacy and get earmarked money for ME/CFS and long COVID every year. And we really see ourselves as a catalyst to leverage donations into bigger dollars. So we do fund researchers, we fund seed money in particular, which enables them to go out and get bigger grants. So we're about kind of being able to, multiply your work, but you could be funding the next big breakthrough. Thanks to the generosity of our board, we have a $300,000 match, which we've extended through December 31st. So I'll just put my shameless plug in to please consider supporting Solve and other organizations in this space. And then I'm going to move on to more Q&A. And maybe Monique, if you could go to the next slide, and we could just kind of leave that up while we're doing some of the Q&A, just in case people want to either join Solve together or donate. And then let's get back to questions. Do you have specific advice on what long COVID and ME/CFS patients should do when they're PCP runs standard tests and the results all come back normal? Is there any kind of specific testing you can recommend that they get, or do they really just need to go find a doctor who's going to listen?
Well, I would say ME/CFS is first and foremost a clinical diagnosis. There's no blood test that's necessarily, although some may be abnormal. I would, if I had to name one test that they can do that it's likely to be abnormal, if that motivates their PCP in some way to have an abnormal test, I would agree with Dr. Hopper's an active stand test, particularly one in the model of the NASA lean test, which is a 12-minute lying and standing test checking blood pressure and heart rate, is abnormal in the vast majority of patients. But it is also helpful, like I said before, to have a curious doctor, and one that runs a couple standard blood tests and says nothing's wrong with you is definitely not curious enough.
Anyone else? Oh, go
Sorry.
ahead. I was going to see if anyone else wanted to comment on that question.
Well, also, you do want lab tests to rule out other things, because, the other day, adrenal insufficiency was the problem, not long COVID, even though they did fail their NASA lean test. Thyroid functions, all the things are important. Mast cell lab testing, which is very difficult to get, but can show some interesting findings. But yeah, so.
And I would that question is somewhat, unfair to the patients. So it puts the onus on the patient. If my doctor isn't giving me the care I need, now what do I need to do? Which is totally fair. That's the situation you're in. But I do think as clinicians, we can kind of take that onus back on ourselves. Getting back to something we discussed previously, I think it's important for us that are learning more about ME/CFS and long COVID, being able to educate our colleagues on it and increase awareness. I think that's something that we're all interested in trying to do. so that you guys don't run into this situation anymore. It's definitely not fair to you all. I would say that some of your physicians are probably just being very earnest. We're really trained when we have a patient who has symptoms and the workup is negative to try and provide reinforcement and encouragement to them. We've ruled out the scary things. You haven't had a heart attack. You haven't had a stroke. That encouragement, sometimes we forget to say, but we do understand those symptoms are very real. Validate what your patient is experiencing. And I think that's what's lacking right now. So you may have a physician that's really in it with you, but they're leaving out that crucial point of really validating your symptoms and trying to move forward and understanding what you're going through.
Can you talk a little bit about, like you mentioned that one test that takes 10 to 12 minutes to do. How do you kind of navigate the fact that most doctor-patient visits are going to be 15 minutes in total? And, you know, how have you managed to be able to get around that? Or, yeah, if you could.
They can do it at home prior to the visit and bring the data.
Okay. That I didn't know, but I'm new to the field, so that's helpful. So are there instructions somewhere that you could point people to, and we could put them later in the resources? But you know, if there are instructions about how to do that test at home, we could make sure to provide that, and then patients could do that at home, and we can put it on our website if it's not already there.
I have a pamphlet I give to patients. I can send that out. Yeah,
that would be terrific. I'm gonna take one that's at the top of the question list. How can Bateman Horne, Open Medicine Foundation, ME Action, and Solve ME, and I would add the long COVID associations as well, work together on MECF medical education to maximize efforts? I think that's a really important question. I'm going to be finally meeting in person, Linda Tannenbaum next week, but we do meet and talk regularly, and I think that's actually a great thing for us to talk about undertaking in some sort of coordinated effort, because it's an enormous undertaking. So it's a great suggestion.
Well, and you guys have cross links on your websites. I don't know if you know that, but I'm sure you do know that, but
yeah, some
of the handouts on your website go to Bateman Horne, and so y'all are doing that to some degree already.
Yep. There's a question specifically for you, Dr. Pittman. The UCLA website still has what this attendee is calling an outdated definition of MECSF that does not have PEM before the 2015 IOM report, and it recommends PT, antidepressants, and lifestyle measures, and they find that disheartening for patients. And they were wondering if that is being addressed, or what. There's a sort of a debate around actually the definition. Most of the definitions do include PEM, but I know one of them doesn't. And if you maybe could comment on that.
Sure. I mean, so I think the website is kind of very general for a reason. The treatments are quite specific to the patient. I'll say I don't unfortunately have much control over what goes on the website, but I can tell you that when we see the patients, we very much dial in the treatment strategy to the particular patient. And I do use PEM as part of the definition personally.
How do you recommend patients most efficiently work with a network of doctors? Because a lot of times patients are given multiple specialists, but because of their fatigue and in PEM, it makes it difficult to coordinate with a lot of doctors. So how do you recommend that they work across specialists?
Yeah, I think that's really challenging. I think that just is kind of owing to the fact that we have a long ways to go in long COVID care, that patients are kind of getting shuttled between all the subspecialists, and hopefully as more long COVID clinics grow and we understand the disease better, we don't require referrals to all the different subspecialties. What we're doing at our site is we're doing these multidisciplinary meetings where we have people from cardiology and pulmonology and physical medicine rehab. We get a big group of physicians together, and we present more complicated case presentations that we can use some help from the experts, so that we can help try and mitigate the number of referrals the patients need. This is a model we're using to try and help efficiency for the patient.
We have a slightly different but somewhat similar model. So we use a hub and spoke model at our clinic. So when the patients come in, they have a general internist, what we call long COVID PCP, essentially, that does the initial evaluation, treatment strategies, things like that. And then for really recalcitrant or severe cases, we refer out to a particular cardiologist, particular pulmonologist, particular neurologist that are mostly, if not only, seeing long COVID patients. And then they feed that back to the long COVID PCP, their general internist, their recommendations, and then they can implement it. And then we also take that because we can't see them that frequently, we hope many times to get their general PCP involved and give our recommendations to them. So it's very organized, it's very coordinated, and I think it's very important to have a multidisciplinary clinic around these diseases.
That's really awesome. But for people like in Milan, Tennessee, I'm it. And one of the things that we do to coordinate care is just have them access their portal and bring their records to me, because there isn't much communication, unfortunately. We try, and I, like you, I pick the ones that are a little more amenable to the long COVID diagnosis and a little more open to some of that. I use the same ones over and over. But it's difficult when you don't have a center like you guys. That's awesome that y'all can do that. But for just people who don't have that I would recommend, as best you can, get your records when you can and bring them. And I know a lot of people have access to a portal and they can bring that with them. I have patients, send me links and things like that all the time, just so that I can actually see the information.
Yeah, and that's something that Solve Together could make easier, because you could actually bring them from multiple portals all into one place. So that's a consideration.
I will definitely be looking at that.
Dr. Walker, have you had luck with insurance companies actually covering those multidisciplinary meetings? My background is a lot in insurance, and I know that sometimes they pay for them and sometimes they don't. Is that something you have to kind of do as a loss leader, or have you, are there successful ways that you've been able to navigate that we might get information and be able to share that with other clinicians?
Yeah, that's kind of a stay tuned answer. We were doing that pro bono with a very interested group of specialists. But as we are expanding our long COVID, Center of Excellence, so AHRQ, we're going to try and do this as a billable service, which we have a model similar to that in other clinics at our institution. And so we will try and make this a billable service, and we'll let you know if we've been successful with it.
Yeah, and it's something, feel free to contact me about it. I've spent the last 25 years working in insurance and coverage. So yeah, if I can be at all.
It's similar, if you guys know, to a tumor board style. So for the patients, if they're unaware, when you have a complex disease like cancer, oftentimes there's specialists that all come together to discuss a complicated case, so that the patient gets really expedited great care. And so we're using that model to try and treat long COVID.
Thank you. Do you have a sense for why it is still so hard for some primary care doctors to accept these diagnoses? One of the patients has talked about having this condition since 1989, and we still haven't gotten to the point where all clinicians are open to it. Other than education, do you have a sense for what's going on there?
Yeah, I have my theories. I think, we tend to be taught a set of diseases in medical school, and we come out of medical school that these are the diseases that exist. And as new diseases arise, we kind of build those into our illness scripts and our understanding of medicine. But if it's not really adopted as a medical community, then I think for most clinicians, it doesn't work into their list of illnesses, their illness scripts. And I think to Dr. Pittman's point, it's all about being curious and having that flexibility and that plasticity to really be able to accept other diseases into kind of that working model that you have. So, I mean, that as you ask that question, it brings up an interesting point of whether or not we should do some advocacy at the level of the American Medical Association or some higher level so that we can get more acceptance of the disease throughout the medical community.
Let me see. I'm going to look for a couple more questions. I think there's some important points here that advocacy is a great tool, but it's very hard to get patients to do this because you're specifically, suffering from this condition. I think that's very true. I think, one of the things that I'd really like to focus on is general awareness of ME/CFS and long COVID and a true understanding, because I think there's a difference between I've heard of long COVID, maybe I've heard of chronic fatigue, but I don't really know what it means. And that's one of the things that we're, trying to put together this year is some more patient profiling to get the stories told. We did a PSA that was very widely seen, but, it was just a start. And so we're looking for media partners and other groups to help us really try to get the word out, because I do think, and I think we need to reduce the stigma so that people will ask and talk to their friends and family. And I think awareness is part of that. I came from the autism space, and the patients themselves can't do any advocacy, and their parents and caregivers are full-time working. So it was a similar situation, but we were over time able to decrease the stigma, increase awareness, and broaden the community. Because I think this is really, the general public needs to take this condition on in the same way that it takes on leukemia and, diabetes and other. And obviously, there's just a huge amount of awareness that needs to go into that. It's clearly one of the areas that we intend to, spend our limited funds on, because, without that awareness and education of the patient population, and the general public and physicians, we're still, kind of, using a spoon where we need a bulldozer.
Another place is the schools. There's a lot of, I've seen with several of my pediatric patients, we really need to educate the schools, the school nurses, just the schools for, absences and accommodations. I've really run into a lot of brick walls on that.
Yep, as well as work, right? I mean, I think the stats are 4 million people are out of work, but I'm sure a lot of other people need a lot more accommodations. And I was talking to a big corporation recently, and I asked what their, because they have great programs in place for autism, for diabetes, for cancer. And I asked what they had in place for long COVID. And they actually responded that almost none of their employees are bringing it up. And I think there's worry and stigma among patients that they're going to put their jobs at risk if they're talking about it. So that's all part of it. But we need to educate, so many people about accommodations and what's needed so that patients can be and continue to be as productive as possible.
One thing I'll just mention really quickly, I was looking at the Q&A chat. Somebody said, please mention the importance of physicians using the ME/CFS ICD-10 codes. I think that is very, very, very important to use either long COVID. There's a code your doctor can code at the end of your visit, and also one for ME/CFS. Very important because that information is collected. It's analyzed by various people, and the more people get these diagnosis codes, I think the more pressure on certain groups to address this pandemic.
Yeah, and the Patient-Led Research Collaborative is working on getting PEM added as an ICD-10 code as well, and that's something that we as physicians need to support, and I think that will be helpful too.
And I'm noticing another important comment. Keep an eye out because we're in the next day or so. We're going to have a letter coming out, but it really talks about the funding and how, you know, there have been some calls even to end funding or reduce funding, which is absolutely crazy for this condition that's had, you know, a little over $1 billion spent once. Where cancer gets $8 billion a year, HIV still gets $3 billion a year, and these are year after year after year. So clearly there needs to be significant increased resources. We are over time already by a minute or two. I would love to ask each of you if you have any closing comments that you'd like to make.
I would just say, bear with us as a medical community. Again, we're trying to increase knowledge and understanding amongst physicians. It's super frustrating for you all not to have validation for these really debilitating symptoms. And we understand that. We're going to try and find effective treatments. We're going to try and bring other physicians up to speed.
And thank you to Saul for hosting this. I'm happy that you're out there doing what you do.
Well, I want to just thank all three of you, Dr. Hoppers, Dr. Pittman, Dr. Walker. Thank you so much for your time. Thanks to all the participants that have joined us for this webinar. We are definitely going to be making it available. It'll be on our YouTube channel. It'll be available on our website. And we will be following up with an email that'll also have a bunch of links to resources that we have and that even, you know, the doctors on this call today are going to be providing. So thank you so much, everybody, for joining us, and let's keep fighting the good fight. We're certainly here fighting along with you.
Thank you.
Thanks, everyone.